Good afternoon, everyone. Thank you for joining us for the second webinar in our series showcasing the findings from year one of our HRSA CDC Public Health Workforce Research Center. My name is Valerie Yeager. I am a site PI at Indiana University in the Fairbanks School of Public Health, and I will be leading our webinar today. Before we get started, I just want to announce that these webinars are recorded, and we will be sharing these webinars online so that others can view them at a later date. And also, before we start, I'd like to introduce both of our speakers. Our first speaker today is Dr. J.P. Leider. He's the founding director of the Center for Public Health Systems, as well as an associate professor in the School of Public Health Division of Health Policy and Management, and associate faculty at the Johns Hopkins Bloomsburg School of Public Health. He's published more than 120 peer-reviewed manuscripts in the areas of public health systems, the public health workforce, and public health finance, and is also the director of evaluation for the Region 5 Public Health Training Center. Second, Dr. Janette Dill is going to be sharing her presentation. She is an associate professor in the Health Policy and Management Division in the School of Public Health at the University of Minnesota. She is also the deputy director of the Consortium for Workforce Research in Public Health, or CWORPH. Her research focuses on job quality and career mobility among the healthcare and public health workforce, and has been supported in her research by the National Institute on Aging, the Health Resources and Services Administration, and other state and federal agencies. I'll turn it over to Dr. Leider.
Thanks, Dr. Yeager. All right. Hey, folks. We are here today to talk about the geospatial variations in supply for the public health workforce. And as we dive in, I want to acknowledge our funders from the CDC and HRSA, and to mention, of course, that the work we're talking about and the opinions expressed here are just those of myself and the research team. We're here today to talk about how to create comprehensive estimates of workforce supply. To do that, we're going to talk about items relating to supply and demand. I should say, as we're getting going, that I'm here part of a team. Sorry, my slides got a little out of sort, so let's lead with the title. So for myself, Suzanne, and Sky, we're going to be talking about supply and demand and geospatial variations therein. So to kind of dive into that, when we're thinking through supply and demand, what we really want to talk about is the conversion of potential graduates in public health, other fields or disciplines into employees. But one of our challenges is that we are a field in transition. And this has been really exacerbated throughout COVID, but it didn't start there. Over the last 15 years, our field has faced multiple stressors. In 2008 through 10 through even 2013, the Great Recession hit our field such that we saw in the public sector millions of jobs lost. But what's different about public health is that while education, public safety, they all saw basically most of those jobs come back. Public health did not see jobs come back for various reasons. Especially local public health saw a substantial decrease in the overall size of the workforce, so that by the time we got to COVID, we had lost between 15 and 20% of jobs at the local and state levels. We also saw a substantial proportion of the workforce planning to leave and expecting to do so based on reasons of voluntary turnover, intending to quit or retire. COVID just made that worse. So when you're thinking state, local, federal, it's a challenging time going into COVID. And we're sitting as we're going into COVID. So sorry. We'll mention real quick. If you do have questions, please use the Q&A, and we'll make sure to answer them as best we can after both speakers. So going into COVID, we're sitting at something like 200,000 staff at the state and local level. How do we think about how to replace these folks that we then know leave during this enormous period of turnover associated with COVID? Some folks have called it the great reshuffling or the great renegotiation, right? There are these macro trends in employment that also are affecting public health, because we've got everything that's going on in the private sector, everything going on in the public sector, and public health is on the front lines of response. So we have all of the turnover associated with that as well. Theoretically, we should have enough people to replace those that are turning over, because we have now 40,000 graduates a year at the bachelor's, master's, doctoral level. But of course, most of our graduates, the vast majority, are not going into governmental public health. They're going into the healthcare sector, to the for-profit sector, to the not-for-profit sector even, but really not into governmental public health. But the question remains, theoretically, what's the potential supply? And so the purpose of our talk today is to talk about the challenge of modeling that. This is part of that challenge. The yellow squares here are state health agencies. The blue triangles are schools and programs of public health. The red circles are 2,500 local health departments spread out across the US. If what we want to think about are how do schools and programs of public health, among other kinds of schools and programs of various kinds, potentially supply health departments, how do you think about what that supply might look like? So this is a lot, right? The national potential supply is a lot. Let's make it a little bit more manageable to visualize. So here's the great state of Minnesota, where Janette and I are from. Again, red circles, maroon circles here are the locals. The yellow is our state Minnesota Department of Health, and the blue triangles are the schools and programs in our state that confer public health degrees. So how do we think about how programs potentially supply health departments? Well, of course, it's not that one school only supplies one health department. You have potentially multiple going on here, right? So how can we kind of convert that into something we can calculate? You create first these things called buffers, right? You essentially create a bunch of these circles around all of these health departments. You see, do they interact with a particular point of interest, in this case, a school or a program? So that's what we've done here. Now, you'll notice that a lot of our rural health departments have nothing overlapping them by way of schools or programs. So one thing you can also do is you expand those buffers. Instead of 50 miles, let's make it 150 miles. Now, it's still the case that some of our schools aren't hitting some of our rurals. That's just going to be true. But most are when you expand that buffer. Another thing you could do are you could repeat the smaller buffer for other kinds of programs, because we know that most of our staff at health departments do not have a public health degree. Only 15% of public health staff have formal public health training of any kind. So that means they've got something else going on. You've got potentially other kinds of health professional programs that could be potential suppliers for employers. Maybe you've got public administration programs. There are also other ones we could add here, like business administration programs or generalized schools. But we'll kind of keep it simple here. So we'll just take a second and say, you essentially repeat this process and you say, what are the different kinds of schools, programs, degree types that I'm interested in for my place of employment as a health department. What are the kinds of staff that I need, the kinds of skills that I need, the educational attainment, at what levels? And that's what we're interested in doing. So we can visualize it in this way, but really what you have to do is you have to geospatially calculate this. And you can do that statistically. So you identify essentially for every health department in the country, for every one of the 7,700 post-secondary education institutions in the country, you want to make this calculation. And you also want to account for the fact that, well, if I'm potentially supplying from one university or community college to one health department, that hypothetically decreases the amount of supply that could go to other health departments, whether state, local, tribal, territorial, right? It decreases the amount of potential supply. So you have to create some kind of weighting system to account for this competitive dynamic. And that's what we do in step 4 is we create kind of a weight to account for the number of health departments, maybe the size of health departments, and that accounts for a differential spread or distribution in the supply. And then kind of finally, what you want to do is you take those weighted counts, you take the number of health departments, and you create this kind of average labor supply. And so what it ends up doing is you come to realize that, well, the urban health departments have a lot of competition among each other, and rural health departments don't have a lot of supply to begin with. But at the end of the day, there just aren't a lot of folks available, which you're about to see for a second. I will point out that we want to make sure to include tribal estimates in here, but it's not always clear between the different data sources where tribal health offices are present, what size they are. So we use the Bureau of Indian Affairs as probably as an overestimate because not every tribal nation has a tribal health office. So keep that in mind as we do our calculations. So where we're at now is thinking about potential labor supply as the average, or kind of the weighted average. So please keep that in mind. This is not the raw number. This is trying to account for the fact that there's competition between the health departments. You'll see in the rows the agency type. You've got large locals, mid-sized, and small, as well as tribes and territories. Now, keep in mind that our territories, some have multiple schools competing, like Puerto Rico will have a few schools and programs, but oftentimes there might only be one. So you'll see some numbers that are a bit out there. But generally, for public health degrees alone, on a couple-year basis here, or an annual basis, you're looking at a relatively small number of degrees. And even at the master's level, you're still looking for MPHs and so on. You're looking at pretty small numbers, even when you're at the kind of the urban area or urban level. And one thing that I want to point out that maybe feels a little counterproductive is that even when you look at the expanded, say, 150-mile buffer range, you actually see kind of less of a supply. And that's because you have more competition, you have more health departments as the buffer expands. So while your supply of schools goes up, your competition for health departments does too. I'm sorry, forgive my cough. One thing that we noticed is that we've got substantial regional variation. Sorry, I'm going to keep coughing. Some regions in the US, and this is using the 10 Health and Human Services region typology, simply have far more schools, programs, and health departments. So that creates kind of a substantial differential at the bachelor's and master's level. A few regions, like say Region 7, in the West have almost, none, say at the bachelor's level, owing to the general availability of supply more so than the number of health departments. Whereas in the East, there are plenty of schools and programs in, say, regions 1, 2, and 3, but there's also a ton of health departments. And so there's a bit of a balance there. One other thing that we wanted to do, as I mentioned earlier, is take an expanded view. Not only look at schools and programs of public health, but recognize that there are all sorts of degrees that might be of interest to health departments. Business degrees, broader health sciences degrees, laboratory-related degrees, administration-related degrees, really expanding the view of what might be of interest. And so you'll see these numbers will be on a completely different scope and scale than what we just looked at. But the thing that I'll point out is that they're also competing within the public sector market and the private sector market with all kinds of jobs. So on the one hand, these numbers might look great compared to what we just saw, but please keep in mind you're competing with almost all kinds of employers out there. So it's really not a rosy picture, right? On an annual basis, the labor market for health departments, especially mid-sized and small health departments, is kind of brutal. That's one of the things that we somewhat expected going into this and what we're really finding after accounting for, just for health departments, not even the other kinds of employers in these markets. All right, so I'll end with a couple key points. We want to highlight, of course, that there are these regional disparities. That it's a matter of supply, sure. That there are some states, some regions where there are really not a lot of programs. So it might be the case that that we really need to think about availability for health departments in getting the kinds of folks that they need. But that also, the bigger issue has long been that when the MPH began, it was for working professionals in health departments. But now that we've got 40,000 people, maybe 43,000 people graduating each year, 10 to 12%, depending on which level you're looking at, are entering the workforce as their first destination. Very different than 50 years ago. And I think there's a lot of discussion and debate about whether that is a success or a failure in our academic field. And I'm not really here to, litigate that. But what I will say is from a supply perspective, what we presented was a best case scenario, right? If you were to think about our numbers and then say, well, what if you're converting 10% of those numbers? That doesn't look great. So the question becomes, how do you better create connections and better incentivize alumni from schools and programs of public health to want to join the workforce? Sure, it's a matter of money and recognizing that we're competing with the healthcare sector, the best paying sector. And certain programs are competing for data folks, which is competing with tech, another great paying sector. That's hard. But there are many other things that we can do to modernize how we recruit people and how we retain them. I will also leave you with this idea that in the past, where we have had pathway programs, they have been less structural and more person-to-person. And there are upsides there. To have strong champions is powerful. But when those champions leave or retire, those programs tend to go away. I've experienced it personally. I've observed it many times. And so that in this period of growth for workforce, it's a good time to invest in structure, because even if those dollars were to go away for whatever reason, there could be structure that remained, and that's a good thing. So then the final point is that as the depth of expertise grows in our space, as we have these incredibly well-trained and educated folks coming out of our schools, wanting to join the workforce and being excited about joining them. It's a matter of how do we do it? So I will leave it there. Thanks very much.
Dr. Leider, could I ask you to respond to a couple questions before we
Oh, yeah, of course, please.
speakers? There was a question asking you to speak to the issue of racial and ethnic public healthers versus the demand. So not the average student worker, but the most in demand, such as the American Indian, polylingual, etc., including the incredible interest in the state health departments and the federal recruiting of Native Americans in competition with schools of public health. It's a little bit longer than that, but could you speak a little bit to the supply and demand in the context of diversity of the workforce?
Sure. So I think I'm gonna kind of separate my answer to two parts. The first part is to recognize that the tribal nations and their tribal health offices look a little bit different than local health departments in terms of the services provided and what the staff do on a day-to-day basis, right? The activities provided. And so the staff that they're looking for kind of reasonably have a different background. I don't think that changes the need to recruit and retain the best workforce you can, and it doesn't kind of change the shortages that are reported. So when you look at NIHB's surveys of the leaders of those agencies, a lot of the same issues are coming up as you see in the local health department reports. So that's a long way of saying, like, there are shortages all around, regardless of setting. The substance, I think, of the second, like to the substance of the question, though, I would say that the public health, like the enrollment of public health schools and programs is really different, especially at the bachelor's level, but at the master's level too, than the kind of general post-secondary field. It's way more diverse. And while American Indians, Alaska Natives are not an enormous portion of that pool, it's still pretty substantial relative to the general post-secondary enrollment. I think that we can do a lot better to increase it. There are some schools, and I'm really proud to say Minnesota is one of them, that offers scholarships to the folks coming with like tribal enrollment and Native backgrounds, like from within our state. So like I think you could do targeted things if you want to increase enrollment from specific backgrounds. Obviously, the Supreme Court has made some of that more challenging, but especially for Native populations, that's separate than ethnicity, right? Tribal enrollment is recognized as different. And then the question becomes, how do you think about separating out graduation from like employment? And I think that there is a real difference between health department interests and like FQHCs, health sciences generally, and clinical. And I don't know that I've seen a lot of pathway programs specifically around kind of Indian country and health departments that has been really strong. And I think that's an area where we could do a lot better.
Two other questions relate a little to your last comment. One is, does the analysis figure in the fact that some of the MPH degrees are pursued by professionals such as MDs who do not intend to work in governmental agencies? And the second I'd like to bring up is a comment that was just added, that students need to be more aware of other pathways such as working at NACHO, CSTE, ASTO, APHL, and so on in an effort to understand the different career avenues for public health and promoting fellowships as a way to help those graduates. Thoughts about either?
Yeah. This is a really key point about the analysis that we're providing. To me, the entire point is to suggest that this is the upper bound on what should be construed as possible. But it's not a value statement that's saying we should be trying to kind of convert all graduates into this line of work. It's more saying that if it were the case, this is what would be available, but we know it is not. And these numbers are not kind of substantial given what we know turnover to be. So this project is paired with a lot of the analyses out there that talk about turnover, some of which I've worked on, some of which Val you've worked on, and others in our field. And we know that turnover is ongoing and it is large. And there has been this kind of thought experiment, some conversations that I've been a part of that say we have so many graduates, why are we having challenges filling the roles? And part of it, I think, is that folks have a hard time getting into health departments. And part of it, as we've shown today, is that it's also a numbers game. There are not actually quite as many graduates in some of these spaces as we may have thought.
Great. Thank you so much, Dr. Leider. There are a couple comments and questions that you may want to respond to. In the meantime, I will go ahead and turn the microphone over to Dr. Janette Dill. She'll be presenting next. Thank you.
Great. Thanks, Val. All right, I'm going to go ahead and share my screen. All right. Well, thank you all for attending today. It's great to see so many people here. I'm going to be talking about an area that's a little bit niche, but I think is growing, and I think is something that probably a lot of people have experience with at this point, and that is the role of community health workers in public health agencies. And before I go forward, I want to acknowledge that I had a lot of help on this project. And in fact, one of our research staff at the Center for Public Health Systems, Chelsea Kirkland, led the analyses and manuscript for this project, which you can now read in the American Journal of Public Health. It was just published. And then we also had help from Harshita Karnik. Like JP, I want to acknowledge the funding for this project. It came from the Health Resources and Services Administration and the CDC. All right, a little bit of background. So community health workers are frontline public health workers. They're used in a variety of ways in public health agencies. I actually think that there is some work that still needs to be done on understanding how community health workers are being used in public health agencies and how they can be used sort of population health efforts. But a lot of times they're employed in public health interventions and leading health equity work. They usually work with underserved communities, and they are often themselves members of or have a close connection and understanding of the communities that they serve. In this project, we are particularly focused on retention of community health workers, and little is known about employment intentions and retention among CHWs, especially in the public health context. And I will say that most community health workers are currently employed in more clinical contexts and work within healthcare organizations. And so the subset of community health workers that are employed in public health agencies is definitely smaller than those in clinical roles. So the goals of this project were to examine the characteristics of the community health workforce in health departments and how it's changed over a couple of time points. The first was in 2017 and the second was in 2021. And then the second goal was to measure organizational factors that are associated with CHW's intent to leave their positions. The The data for this project came from the Public Health Workforce and Interests and Needs Survey called PHWINS. Data were collected in 2017 and 2021. And I want to say and acknowledge that the PHWINS data set is funded and collected by the DeVomont Foundation. So in research, we talk about things like dependent and independent variables. I would say, the main thing, the dependent variable, the main thing we were interested in measuring in this project was intent to leave. So is someone planning to leave their employer? And in this case, it was a CHW's intent to leave within 5 years. Okay, so when we think about intent to leave, a lot of people use those terms use the terms intent to leave and turnover interchangeably. I would say that intent to leave is a proxy for turnover, but it's not a one-to-one relationship. Not everyone who intends to leave their job actually will leave their job. And some people leave their job who have no intent to leave. So there's definitely a tie between intent to leave and turnover, but they're not exactly the same thing. Instead, I would say it's helpful to think of intent to leave as sort of a proxy for overall job satisfaction. We had 3 key variables that we were interested in. The first was organizational support, and I'm going to say just a bit more about that on the next slide. The second was satisfaction with pay, and that was just a single item indicating how happy someone was or satisfied with the pay that they were receiving. And the last was job security satisfaction. So how secure did people feel in their jobs? And I will say, just to give some context here, in general, CHWs are not highly compensated. It tends to be definitely a lower wage kind of position. So I think that's sort of helpful context. And then in terms of job security, a lot of CHW jobs are grant funded. And so there can be a certain amount of instability in the kinds of jobs that they're filling, where they may only know that they have funding, guaranteed funding for their position for a year or two. In addition to sort of that focus on organizational characteristics, we had some additional factors that we considered, including a person's gender, their age, race, ethnicity, whether a person reported that they were bullied or threatened, PTSD factors, the tenure of their public health practice, and the type of agency in which they were employed. I'm going to talk just a second about the measure of organizational support that we use. So we used a scale, which is where you take a bunch of items and combine them together. We use confirmatory factor analysis to develop this scale, but there are a lot of items in the scale. And I think when you say the words organizational support, people don't really know what you're talking about. So I wanted to give some specific examples of the items that were included in our scale of organizational support. So they included things like creativity and innovation are rewarded, communication between senior leadership and employees is good, my training needs are assessed, employees have sufficient training, there's opportunity to learn from one another, and then there's a few other things like I am satisfied that I have opportunities to apply my talents and expertise. I think my organization is a good place to work. And then finally, my organization prioritizes diversity, equity, and inclusion. So for our methods in this project, we first looked at descriptive statistics of the CHW workforce. We just wanted to know, what do these workers look like and how many of them are there? So we looked in 2017 and 2021. And then we ran some regression models to examine what predicted intending to leave your CHW position or intending to leave your employer. And for those models, we only used the 2021 data. And this was because some of the variables that we wanted to include in our model, including whether or not a person was bullied and whether or not they had PTSD symptoms, were only collected in 2021. So we didn't have any data on that in 2017. And then after we had run our regression models, we calculated the predicted probability of intent to leave across 3 independent variables, which I mentioned earlier were our variables of interest in this study, which were organizational support, pay satisfaction, and job security satisfaction. All right, overall, the estimated number of CHWs within health departments increased from about 3,300 in 2017 to 4,600 in 2021. This is a 38% increase over that time period. We do like to sort of give a little caution to this estimate because the sampling frame for PH wins for the survey changed some between 2017 and 2021. So it's likely that there was some increase in the number of CHWs employed by public health agencies. However, the exact percent might be an artifact of the change in the sampling frame. CHW's intent to leave increased from 25% in 2017 to 28% in 2021. I actually think this is remarkably low. The increase over time is not very high given the context of everything that had been happening at this time. So between 2017 and 2021, of course, there was a pandemic. And then if you think back to 2021, as JP was talking about, this was the time of the Great Reshuffling. There was, a booming economy and lots of opportunities for getting all different kinds of jobs. So I think it's actually quite remarkable that we only saw a small increase in that time in the percentage of CHWs that intended to leave their positions. I want to just briefly highlight some CHW demographic characteristics. So first of all, like many frontline healthcare positions, CHWs are overwhelmingly women. It's 82%. This is actually, however, only a little bit higher than the overall public health workforce, which is 79% women. So not that different from the public health workforce. I do think that one thing that is notable is that about 27% of CHWs are Black or African American, compared to just 15% of the overall public health workforce. About 33% of CHWs are Hispanic or Latino, compared to 18% of the public health workforce. And there's a lower percentage of CHWs that identify as white. So 30% of CHWs identify as white as compared to 54% of the overall public health workforce. So in general, the CHW workforce is much more diverse than the overall public health workforce. All right, this is just a quick summary of our research findings from our regression model. In this slide, we only show variables that were statistically significant. I'm not going to spend a ton of time on this because I'm going to move on to the next slide with findings that are much more easy to interpret and understand. But I will just briefly say that we find that individuals who have medium or high rate their organizational support as medium or high are less likely to intend to leave their jobs. And the same is true for those with high, medium and high pay satisfaction and medium and high job security satisfaction. Women are more likely to intend to leave their jobs than men, or people who do not identify as a woman. And then older individuals, not surprisingly, less likely to leave their job. That's true across any occupation. Interestingly, those who said that they were bullied or threatened were significantly more likely than those who are not to say that they intended to leave their job over the next 5 years. In this slide, we're showing the predicted probability based on our model of CHWs intending to leave their job, and I'll just help you a little bit with the interpretation here. So if you look at the far left columns, that is the predicted probability of intending to leave your position based or conditional on organizational support. And those who report that they have low organizational support, about 50% of them intend to leave their job over the next 5 years. And you can see that in the far left column. However, if individuals report medium or high levels of organizational support, the percentage that plan to leave their job drops down to 25 and 24%. So there's a really big difference between those reporting low organizational support and those reporting medium and high. And then we see the same pattern for pay satisfaction and job security satisfaction. Those who report low levels, for about around 40% of those individuals intend to leave their job after 5 years, whereas if they have medium or high levels of pay satisfaction or job security satisfaction, those percentages drop to about a quarter. All right, so to summarize, we've seen that there has been large growth in the employment of CHWs and public health agencies. This is a diverse workforce. They're more diverse than the overall public health workforce, and there's a greater percentage of CHWs are Black and Hispanic as compared to the overall workforce. Our organizational, our measure of organizational support contains many actionable items, and it's clearly related to individuals' intent to leave their organization. So I just want to highlight a few of those quickly. And again, it's really the difference between those who are reporting low organizational support versus medium or high. And so the question is, how do we get people from that very low category and bump them up to a medium or high level? So one of the things that really emerges is providing resources needed to do the work. So I think one of the challenges with the CHW role is that it's sometimes a little undefined because it is a relatively new occupation, especially in some settings. It can be hard for individuals to understand their role within an organization and understand how to do their job well. And so, public health agencies can support workers by really providing them with the resources that they need to do the work and really, thinking about the scope of the work that the CHW is supposed to be doing and whether or not they need training or additional skills in order to be able to do that work well. A second theme that emerges from this measure is that individuals need space to do their jobs with autonomy and control. They need opportunities for creativity and innovation. And this is true across all occupations. This is always true in every study of intent to leave. People like to have a sense of control over their jobs. They want to have the ability to have input into their job tasks and to feel like they have a say in the work that they're doing. Here we see that CHWs are no different. They want to have opportunities for creativity, for innovation, and for making a meaningful difference in the job tasks that they're doing. Another big factor in all retention studies, and is also true here, is opportunities for career development and professional development. I think it is a feeling of support from an organization when organizations invest in individuals and help them to achieve their career goals. And then it also, contributes to the first item on the list, which is providing resources needed to do the work. So, if this includes tuition money for classes or opportunities to attend workshops or conferences, those kinds of investments in workers go a long way in terms of organizational support and then overall retention. And then the last is prioritizing diversity, equity, and inclusion. As shown in this study, the CHW workforce within public health agencies is more diverse than the overall workforce generally. And so making sure that DEI efforts that are focused internally can be really important for retention of these workers, as well as efforts, focused on communities. And then finally, I just want to add a quick note about the job security issue. As I mentioned earlier, a lot of CHWs are in grant-funded positions, and that limits the job security of CHWs. And this is something that we hear very routinely is a big challenge. People don't stay in their job because they're worried about their grant funding ended. And so or their grant funding does end, and then they are forced to look for a new job. And so this is a huge challenge of this particular occupation. I think, some states have made efforts to make it so that community health workers can bill for their services. Minnesota is one of those. However, I think what we hear is that there are a lot of constraints around those billing opportunities. And so often organizations don't choose to bill for CHW services because it's not a sustainable option. This is just an ongoing challenge of how we make CHW positions more sustainable, more secure for the workers who are in them, and not so dependent on short-term grant-funded positions. And that's it.
Thank you, Dr. Dill. We have a question about the job descriptions for community health workers. Is there a template available that others can use to understand community health worker roles? And there was a question in the chat about, are community health worker roles ever remote positions?
That's a good question. I would have to look to see if I could find a template for job descriptions specifically focused on public health agencies. I suspect that there probably is one.
We've got one.
Huh?
We've got one.
You got one? Okay.
I'll put it in the chat.
Awesome. And, you know, I would say I don't know the degree to which CHW positions are remote in public health agencies, but certainly a lot of healthcare interventions that do use community health workers really focus on communication via text and often through video visits or other kinds of technology. So it is possible, I think, to have CHWs in a remote role because of that technological kind of communication. However, I think a lot of community health workers are sort of more on the ground.
There were also questions about whether or not the slides will be available and whether there's a link to your recently published study. And I just want to note that the consortium will be sending out links to slides from today, as well as the link to watch the video if you want to share it with anyone. And they can put the link for the manuscripts that are published related to this work in that email, as well as a follow-up thank you.
Yeah, absolutely.
I also want to mention that we have a third webinar. So we actually have 5 of these sessions planned, and our third webinar is coming up soon. I believe we're going to be looking at it just a moment on the screen. But that webinar is going to be held on Wednesday, January 24th at 1 Eastern, 12 p.m. Central Time. And I will actually be presenting one of my studies along with Dr. Kate Beatty. Dr. Beatty is going to be presenting on career ladders to recruit and retain a diverse public health workforce. So that does talk a little bit about one of the comments in the chat regarding career development opportunities. And then my presentation is about what agencies have in their workforce development plans that have been submitted to the Public Health Accreditation Board as a part of their accreditation requirements. And let's see, there's another comment in here. What can local health department leadership, this is for you, Dr. Dill, do to prioritize community health worker work plans to include on-the-job training and step into higher level positions?
Yeah, so this is a big challenge for all, I would say a lot of frontline healthcare workers, and it's not unique to community health workers. You know, I think that you can, to a certain degree, build in ladders, right? Like you can have CHW1, CHW2, you know, like things like that. I think those ladders are often fairly limited in scope, and their ability to sort of move people up in terms of their career as well as salary. I think another opportunity is, you know, to work with individuals to think about how other career pathways. I'm a little hesitant to say this. You can see I'm sort of backing away from my words because of course we want people to stay in the CHW role. It's very important, right? However, I always want to acknowledge that they often are very low wage positions, right? And we want to give people opportunities to grow their salaries. And so working with CHWs to think about other roles or pathways that they may also want to move into is always another option. Then, of course, always drawing on tuition reimbursement opportunities can be, and helping people connect to those kind of opportunities can be very valuable. My experience with a lot of different types of frontline healthcare workers is that they struggle to sort of identify potential pathways and how they interact with higher education. And so I think working with individuals to think about those opportunities can be really important. The other thing that I'll just say about CHWs is that there is a certification process in Minnesota that can be an important professional development step, getting that certification, and then you are able to bill to Medicaid once you have that certification. That can be a career advancement opportunity. I hope that answers that question.
Thank you. The individual, Kathleen Sanchez, who submitted that question, had said that, very few opportunities exist to move up without additional educational credentials.
Yeah.
And you did address this. We've seen in our work related to benefits and promotional opportunities for working in the workforce that many state health departments are starting to implement tuition reimbursement.
Yeah.
But often the small local agencies, unless they're in a centralized state where that benefit is provided for all employees, rarely have that tuition reimbursement benefit. So it is a limitation, especially given that community health workers tend to work at the local health department level.
Yeah, that's a huge limitation. Even when tuition reimbursement is available to, especially for frontline healthcare workers, it can be hard for them to access tuition reimbursement benefits. If you look across the healthcare workforce, the people who are most likely to access it already have very high levels of education, right? So helping individuals with lower levels of education to understand how to use tuition reimbursement and gain access to that, can be an important role.
Another question is, what can be done to raise the salaries of community health workers? And are we sure that they're making living wages?
That is, I would say I'm not sure about that at all. It's a little bit hard to understand the wages of community health workers. It's a little hard to identify them in large data sets and to track their employment because they're not well documented in sort of our governmental data on occupations. So yes, the wages are low. I would say wages for community health workers are consistent with other frontline healthcare workers like medical assistants, nursing assistants, which are all dominated by women, all hands-on frontline kind of care positions. So it's not unique to community health workers. It's just how we value this kind of care in our economy. And so I think that it's a much bigger question of like how we value women's work, how we compensate it, and how change can be made around that. And so, I think that one of the ways that we have really tried to raise women's wages is around professionalization, credentialing. You can think about like certifications required, things like that. That's always a recommendation, you see. I don't know. I don't think it works that well. It doesn't seem to work that well. We still see persistently low wages in a lot of women's work. But there are other strategies too, like unionization and things like that. But this is it's an enormous challenge.
Another individual has asked, why are more community health workers in clinical spaces rather than in public health spaces? And there was a question earlier that perhaps Dr. Leider or you, Dr. Dill, could respond to about trends towards contract workers. Any comments about either of those?
Well, I can just quickly say, I think that more community health workers are employed in clinical settings just simply because there is so much more clinical care. It's just such a it's just a much larger employer. Clinical settings are a much larger employer in the US. So there are just more opportunities for jobs there.
Okay.
I will say that the current kind of contract versus permanent environment is unlike anything we've seen in the modern public health space. So it is still the case that most of our positions are tended toward full-time positions. But when you look at job postings, job boards, and you're somebody coming out of coming out of school or somebody who's looking for a new position, you get a very different sense of what governmental public health is now versus 5 years ago. Because almost all of what you see are time limited, term limited, non-permanent postings. Largely, this is associated with the recovery money or the FIG money. And it makes sense why health departments would do this, right? That money runs out. And that money is supposed to support the transition from recovery money to whatever's next. But if you're a health department and you know you've only got a few years left, many states won't even let you make that a permanent position. And even if they did, why would you? But consider being the potential employee on that flip side, and all you see are time or term limited positions. You kind of have two choices. You can get that through an agency, the health agency, or you can go to a staffing agency and get paid 15 to 25% more, but the term is shorter. It's a strange position to be in and not one that I envy. But it's really not what the field looked like 5 years ago. And I'm not sure what the field's going to look like in this specific area in the next 5 years. I will also say that it's not what most positions are. It's a relatively small percent of the total kind of corpus of our workforce, but it's what the frontline recruits are seeing, because it's what almost all the open positions are. So it's a very strange environment for recruitment right now.
And one last question in our last 3 minutes for Dr. Dill. Can you talk about the certification for community health workers? What difference does it make for a community health worker to have one?
Sure. You don't have to have a community health worker certification to practice. I would say I don't think that's true in any state. It's always voluntary. But it does include taking classes at community colleges, at least here in Minnesota. Other states have their own curriculums that they've developed. There's not a comprehensive curriculum across states. I would say the biggest difference, I expect that my expectation would be that some employers would value the certification and would be willing to pay higher wages for it. But the biggest difference is that you, once you have the certification, you can bill for your services. So you can bill Medicaid, or the organization that you're working for can bill Medicaid on your behalf for the services that you're providing. As I mentioned earlier, I think that the reimbursement for CHW services is very low. So many organizations opt not to, because the bureaucratic challenges of doing that billing is like the bureaucratic challenges are too high for the amount of money that you would pull in for the CHW services. That's the certification that you can get in Minnesota is similar across many states, but it isn't standardized. It is state by state.
And then one last question came in saying, is there any research on the ethical use of community health workers in lieu of other trained professionals such as social workers or health educators?
Yeah.
This individual reports seeing positions that have been, quote, downscaled to a community health worker role, but then certain services are cut. Is this a, quote, right sizing, where organizations are aligning needed services with the right positions, or a money-saving tactic at the expense of predominantly BIPOC women?
Yeah. I think that's a really good question. It's a really fair question. I think it's really challenging, right? Like you want to be able to have people fill jobs and serve their communities and not have the barriers of education, like a degree in social work or a license in social work, which is prohibitive for a lot of people. On the other hand, these jobs pay low wages, and so they can be used to undermine professionals like social workers and other professionals. I think it's a big tension. It's another area where we see this a lot is through peer counselors in behavioral health who, can fill the role of a lot of behavioral health positions now, but don't have the professional training as well. And the question is, are you providing access to these kinds of services and giving people access to these kind of jobs, or are you undermining people who have invested in education and who already, especially in behavioral health and in social work, who already are earning fairly low wages and don't need their wages to be undermined by individuals who have lower levels of education? I don't have an answer to that question, but I do think it's a really important issue and one that should be, a continued point of conversation.
Thank you. Thank you to Dr. Leider and Dr. Dill. I hope this has been a valuable conversation for everyone who's joined us today, and we'll look forward to seeing you on January 24th for our third webinar series. Have a nice afternoon.
Thank you.